right. Good evening or afternoon, everyone, depending on what part of the country that you're joining us from. I'm Julie Stacchio. I'm a hematologist in Saskatoon, and I'm going to help kind of guide the conversation tonight as we talk about COVID and some of the obstacles and practice changes we've noticed across the country, and then what the new normal might look like us as COVID seems like it's here to stay for the next little while. We're happy that you all can join us, and I hope you find this informative. We've put together a bit of an agenda, but would also like to welcome your questions in real time. And in order to make that practical, just wonder if you can use the chat function. I'm sure most of us are now quite prolific in Zoom or WebEx and know the chat function on the bottom. And if you click on it and make sure you address it either to all panelists and attendees, or if there's a specific panelist you want to talk to, fine with that. I'll try to flag them and ask our panel to comment on them as they come up, and we'll try to get that done in real time. So I'd like our panel to introduce ourselves. Unfortunately, we're not listed in any order from east to west or looks or age. So I'll just turn it over to the next person on the list there.
Daryl White, I'm a hematologist in Halifax. And
I'm Kevin Song. I'm a hematologist in Vancouver. I work with the Leukemia Bone Marrow Transplant Program there.
And I'm Hira Mian, and I'm a hematologist at the Juravinski Cancer Center in Hamilton in Ontario.
Perfect. So you can see we kind of have the majority of the country covered. I understand they're doing a French version of this next week sometime. And so we've left the French francophones off the list tonight. Just wanted to run through the objectives of this program. As I mentioned, we kind of want to talk about the Canadian landscape in terms of what we're doing on a day-to-day basis for during the COVID pandemic, but now that things have settled down, kind of where we're looking to in the future, some of the practical perspectives of the experiences, and both from a transplant eligible and transplant ineligible frontline, and then even all the way to some of the end of life challenges we've faced. And then, you know, some of the changing ways we're seeing patients and what might be just during the pandemic and what might be here to stay. And we hope that you can glean some tidbits from the panel that we've assembled, but certainly welcome your comments and perspectives in that chat function there as well. Just go to the next slide there, Paul. Just some housekeeping perspectives. This learning program is sponsored from BMS. We did develop the content ourselves, the four of us. The opinions expressed are solely our own, and we're definitely sharing our own experiences and quote unquote expert opinion. And it's probably too early in the stage of COVID to make any really informed evidence-based medicine claims. I think if you followed COVID in the news at all, you'll find that it's rapidly changing. It certainly seems like it's been here for a lifetime, but the evidence seems to change on a daily basis. Talking about kind of what happened when we first recognized that COVID was here and we had to acutely make some patient management decisions.
So I think in British Columbia, we got involved, or at least we had experience with COVID very early. As you know, some of the earliest cases were happening in British Columbia with the person from China who got it, and subsequently the person who got it from Iran. And so these were early cases that I think forced British Columbians to think about this and had some time to think about where we would go in terms of preparing for the expected pandemic that was going to occur. So this was always at the top of our minds, and as things progressed, and by March it was clearly evident that the cases were increasing, the hospital began to have further discussions with our administration. And in particular, the director of our group was very, very thoughtful in terms of trying to be ahead of the curve in terms of how to prepare for the pandemic that was happening. So even before the cases had expanded, we had already talked about how we would begin to delay the myeloma transplants and with that in mind to advocate to the Cancer Agency for further cycles of induction. And importantly, we had to communicate with our colleagues who referred the patients to us that this was happening, and therefore they have to be prepared for taking these patients, care of these patients for a longer period of time as we delay the transplants until a safer period would occur. With this in mind, of course, we had regular discussions and communications within our group so that we could all be prepared for this. And I think that we were very lucky that by the time the greatest number of COVID cases were coming to our hospitals, we had already been in a situation where we had decanted most of our patients in terms of trying to reduce the number of hospital visits, hospital beds, so that we ourselves could deal with these patients as well as mitigate any risks these patients would have in terms of being exposed to COVID or having COVID in the midst of treatment. We're continuing to evolve our approach, and I think this is something that we're understanding is something that is not static. It is not over. We need to continue to adjust to the situation. So I think that we were very lucky, in fact, that we had the first 2 cases back in January, which allowed us to psychologically as well as practically prepare for the patients that were coming along.
Kevin, let me ask you just quickly before I give you my Saskatchewan experience. Did you do anything specific in terms of myeloma patient treatment? Moving your bisphosphonates out, delaying, those kind of things?
Yeah, so I think, as you know, there was a lot of things that were going on from an administrative point of view, but also from the point of the experts that are out there. And, without too much evidence, I think a lot of people were beginning to recommend certain adjustments or changes that needed to be done to safeguard our population. And as this was happening, I was trying to keep up to date with what other groups were recommending, such as the International Myeloma Working Group, the Europeans, the Americans, and certainly the recommendations were there that we should try to expand or delay transplants and increase the number of cycles of inductions, and we were doing that. Regarding things like bisphosphonates, there were recommendations coming out of ASH that we should make the zolgenic acid or pamigenate, give it every 3 months as opposed to monthly, or even delaying it even further for those who are extremely stable. And so we were following those recommendations. In addition, of course, the patients were very in tune with what was going on in the province as well as across the country. And a lot of patients were asking these questions. Is this necessary? Do I need to have the transplant now? Can I delay this? So I think, interestingly, there was a huge amount of buy-in from the patients in terms of trying to look out for their medical health, both from the perspective of myeloma, yet as well the perspective of COVID. So how do I keep my myeloma in check, yet at the same time not expose myself to undue harm? So, so this was actually surprisingly easy to explain to patients. So we were making those adjustments as you had indicated.
Yeah, I think, in Saskatchewan, we certainly have not seen the amount of COVID that other provinces have seen. And even though we had relatively low numbers, the initial, we need to keep people out of any of our buildings or facilities. You got to figure out how to delay the bisphosphonates. Certainly that administrative challenge, I think, is something that likely is common to us across the country. It'll be interesting to hear what Daryl and Hira have to say as well. I agree, patients were very accommodating to delaying bisphosphonate therapy to even the transplant delay, recognizing they didn't want to be anywhere near a healthcare facility and having to leave their home if they didn't have to at all. Certainly now our biggest challenge is repatriating those transplant patients and recognizing there's a bit of a backlog in the competition with all the other transplants that we have. And then the only other thing I'll point out is, as I'm sure as everybody else did, we had to put together this pandemic plan and this level of treatment priority. And for myeloma not being a curable malignancy, that was a tough one when you realize that if things got really bad with COVID and, from a resource perspective, we might be looking at making some tough decisions, and you actually had to put that down on paper. And that was a very unique experience to have to go through. Kira, what about you guys?
So thanks, Julie. I'm just thinking of Kevin's point, and it seems like it was so organized. I have to say, I felt at least at my center, it was just a little bit unanticipated. So the first time we had thought about COVID, we were like, well, we're close by Toronto, but not really in Toronto. And, things happen in Toronto, not an hour away from Toronto. And so our first COVID really talk at the hospital was when one of the healthcare providers who ran a big clinic ended up being tested positive for COVID in a clinic just close by us. And then suddenly it was on everyone's agenda and mind, and a lot of management around that acute situation. So I think that's when it was like, okay, well, it's here and it's in Hamilton. We really have to make some adjustments. I would say we were probably, slow to start up, but we caught up very quickly. Huge adjustments were made in terms of going from, and I'm sure as most people, going from entirely full clinics to virtual clinics that were almost, for the most part, we were seeing patients or talking to them over the telephone. We were also able to institute, again, transplant was a big concern up front, and similar to both what you and Kevin has said, patients didn't really want to get transplanted. And so we, at some point, we're still doing transplants, but then we actually entirely halted them at one point. Transplant ineligible patients, again, a lot of conversation about some patients coming in for Velcade, and as much as we could, we tried to put those patients on oral regimens. I think some of the good things that we were able to do was that our pharmacy was absolutely fantastic. So for most of our Revlimid patients, we were actually able to send it to their house, and I can tell you patients absolutely loved it. Similar to the other comments both of you brought up, supportive care is probably where we started lacking, so bisphosphonates were entirely stopped. And one of the unique challenges that at least we had in Ontario, which I'm not sure if other provinces had it, is that our light chains can only be covered the cost if they're done at a hospital and not at an outside lab. So that was a unique situation where, we were trying to push all the labs to an outside institution, Life Labs or wherever else we could to keep the volumes down, but we couldn't get light chains, which for some myeloma patients were absolutely essential. So then we were doing this thing where older patients, we were bringing them first thing in the morning at 8 a.m. and then they would go home, and then I would call them, and then the pharmacy would send them the Revlimid. So we made some adjustments and we've gotten through, and now we're dealing with our biggest challenge has been how to restart transplants, and also the ethical framework about when you have, at our center, we probably have easily about, I want to say 30 to 40 delayed transplants, and some patients are, again, on their 8th, 9th cycle of Cyborg. So how do you decide who will go first? And so that's been a huge challenge currently that we're dealing with.
Gotcha. Thanks, Kira. Daryl.
I think many of the same issues that have been already discussed. We were relatively late having COVID here, and it's been sort of like Julie's experience. I think there have been, over 1,000 cases, but most of the COVID patient experience has been in the elderly nursing home, long-term care type setting, and virtually all of the deaths have been in the long-term care setting. The provincial borders were closed relatively early before there was much COVID, which is important here because we do see patients from the 3 maritime provinces. So patient travel was possible, but it was probably quite difficult, actually. So my usual patients that would come from PEI or New Brunswick, we switched really to virtual care, and the routine patient visits really turned to virtual care as well, which for the most part has worked very well. And actually this afternoon I saw a CMA survey that had been done of about 2,000 patients, and patients have appreciated the switch to virtual care as well. So it was interesting to see the numbers. They've switched from all across the country, virtually all in-person care, to virtually all for the most part telephone care, and the patient preference actually was telephone over video or other virtual means, which is interesting. And I must say, in my clinic, I found telephone was the most efficient. We had the option of Zoom, but again, for my patient population, which for the most part is older people, many of whom live in rural areas, it really wasn't practical. So pretty much everybody has a telephone, but not everybody knows how to use Zoom. So for the most part, that worked out well. Like others, we stopped the bisphosphonates for the most part, put them on hold. The amount of blood work, I typically do my routine is monthly blood work for virtually everybody, and switched that to in stable, well patients to every 3 months, and some less than that even. And like others have said, our patients really weren't looking to come to the cancer center to be seen. They're quite happy to be at home. A lot of what we do is distributed around the province or elsewhere. So I didn't change people from Velcade to Ixazomib. We continued for people getting Velcade, they continued, but much of our treatment is actually not in Halifax. It's distributed around the province. We did, there's a question there about steroids. I did reduce a lot of dexamethasone. I do tend to typically keep the doses higher than some of my colleagues across the country maybe do, but certainly drop the dose here. One thing that we hadn't touched on is our study patients, and a lot of my patients are on trial. The trials were very permissive, so depending on the sponsor, we were able to either sometimes skip doses, certainly reduce the blood work. We did switch the patients getting intravenous daratumumab to subcutaneous, which was, has been a major advance. It would be nice to do that for all of the routine patients as well. We had used the subcutaneous in some previous trials, but to have our, Maya patients, for example, on now subcutaneous Dara is a great thing, and I hope it continues post-COVID. We'll see. And like others, we delayed transplants, so the leukemics and the, folks with aggressive lymphomas continued to receive their transplants. Myeloma, for the most part, was delayed, except aggressive or high-risk patients. They did proceed. We do have a backlog now, although the backlog is not huge, and I think we'll catch up by the end of the summer, I would think. Like Julie, we did have to create a priority list, and we had to look at not just hematologic malignancy, but across the full cancer spectrum. What if we weren't able to deliver chemotherapy to everybody? And non-curable malignancies were not at the top of the list. So somewhat difficult when you're looking at prolonging somebody's life potentially, quite significantly. So it would be nice to have a national approach to that, I think, because it lends itself well to that. But perhaps we'll do that before wave 2. I did attend on our ward during the time, and it was interesting I think the risk of COVID for patients isn't actually from the patients themselves. We had a no visitation rule, so there was no family, there were no family coming. The risk, I think, is actually the medical care team, and we did have a member of the care team in the BMT unit turn out to be positive for COVID. Fortunately, didn't infect or didn't transmit to patients or other staff. So the person was symptomatic fairly early on, I think. And universal PPE. I think other places in the country are using 2 masks per day. We're making do with 1 in a paper bag. But anyway, you sort of get used to having your mask on all day, as I'm sure everybody on the phone is as well. So I think that sort of at a high level sums it up for the changes. Some it would be nice to keep, like the virtual care, and I think that's being negotiated now between the Department of Health and the Physicians Association.